joining us again for our 5th Fall Prevention Implementation Sharing webinar. We're glad you were able to make it. Today, we have a guest speaker. We have Dr. Pat Quigley, who's going to be talking with us. But before we get to her presentation, we're going to just do very briefly, just quick housekeeping items like we always do, and a quick update on the upcoming webinar topics that we have lined up. Then, as I say, we have Pat Quigley today, who is going to be talking about evidence for fall prevention strategies. And in particular, she's going to be addressing a number of questions that we have received from all of the hospitals who are participating in this initiative. We know that there are lots of questions that you guys struggle with, and there's not always good evidence out there. So Pat Quigley is going to do her best to attempt to answer the questions that you have, and certainly we hope, if you want clarification on any of the questions or any of the answers that she provides or presents on today, that we encourage you to ask questions. You can do that by typing into the chat or the Q&A box as well, or raising your hand, and we'll open up the lines for you. And then at the very end, we'll just end with any additional questions that you have. And so let's just quickly go over some of those housekeeping items. We've gone over these on most of the webinars, so I'm trying to keep it brief. Just remember to use the little hand icon if you want to ask a question verbally. You can also use the chat panel or the Q&A panel that you'll see on the right hand of your screen. What I ask you to do is to just make sure that when you type in a question or use the chat feature, that you use that drop-down box and make sure you send it to all panelists. You're all in the panelist position, so you should be able to see the question. You can also direct it to the host as well. That's fine, and she'll make sure that we all get it. Now, also, many of you have heard some background noise, so I would like to encourage you to please keep the background noise to a minimum. Please use the mute feature on your phone or on the WebEx system so that we don't have that kind of disruptive background noise coming in. You have to keep everyone unmuted, at least for the purposes of being able to ask questions, but if we hear a lot of background noise, sometimes it's hard to pinpoint where it's coming from. So just please try to be cognizant of that and try to minimize it as much as you possibly can. So with that, well, I did want to just tell you about the upcoming webinars that we have planned. So in January, we have a webinar that will be presented by Patricia Dykes. She's one of the experts that is also the standing experts for this fall prevention program. And she's going to be talking about care planning for individual fall risk factors and using the electronic health record while doing that. So I think it's going to be a really great presentation, and I encourage you guys all to come to that particular webinar, and also think about questions you might want to ask during that webinar. And then beginning in February and going through April, we're planning to have each of the hospitals during one of those months present on just update on how your implementation efforts are going. We don't expect you to have completed your implementation, but what we're looking for is having the hospitals, each of the hospitals, during one of those months, just sort of share what your experiences have been so far, and potentially ask questions, of other hospitals and our experts who will likely be on the webinars. So that's what we have planned for the future. And with that, I'm going to briefly introduce Pat Quigley. As you all know, you've seen several of the webinars that the training webinars that she's presented. She's with the Veterans Integrated Service Network, and she's nationally known for her research in patient safety, and particularly for the work that she does in fall prevention. So we're really lucky to have her on today and available to answer all the varied questions that you all have. So with that, I'm going to pass the ball over to you, Pat. Let me find it.
Thank you, Michelle.
Let you take it.
You got it. Thank you so much. And colleagues, I am just so delighted to be able to be with you on this call. And I'm so sorry that I've missed so many of the calls just because of other competing demands. But thank you for the great work that you've been doing, because it was very exciting to be part of the expert panel to help prepare the AHRQ Toolkit, and then to see this project go forward. It was actual testing of implementation, not change for the heart, to be able to implement change. We know that. So I thank Michelle so much for your leadership, and Gloria Stables. And I know I've had really great expert guidance from Kate Walsh and Dr. Patricia Byers that's on the call here with you, Kate. And I know also Julia Neely has been on the call. Oh, good. Julia's on the call with us now, Patricia Dykes. So I just want to just acknowledge all of their great leadership too. And with that, we're going to go ahead and go forward with this presentation, because I have this hour to help talk to you and influence the changes that you have been making. So there's some topics here that you can see. There's a little bit of background noise there, but you know, I want to be able to put some things in context for you. And we're going to talk a little bit about the level of evidence. I want to spend a little bit of time with you about the Joint Commission Sentinel Alert. I was asked to help focus a little bit on targeted interventions, the bed alarms, bed rails, surveillance, protective strategies, and then some prevention strategies to help you, especially with mental health. I've done a year's worth of work in psychiatry. Post-fall huddles and using data, and then the population-based approach to fall and injury reduction, which Julia Neely and I have a long-standing implementation project that we've been doing across the VA and really going after a population-based approach to injury reduction. So hopefully we'll have some time, too, to be able to answer some questions. So just, again, delighted to be able to be with you, be able to do this kind of sharing with you. With that, let me, you know, we are all trying to take the knowledge that we have to be able to improve outcomes. And that is indeed, you know, the essence of the Agency for Healthcare Research and Quality's Fall Prevention Toolkit, is to really help implement some interventions to be able to have an impact on patient outcomes. So all of us come to this implementation project with knowledge, and when we're doing the work in patient safety, which Julia and I have done for years, we are always trying to work with people and help them take their knowledge and be able to affect outcomes. We have three complementary perspectives that we integrate to be able to take the knowledge that we have and be able to affect outcomes. So let me just briefly talk to you about this, because I know that this is what you're doing as well. Sure, many of you know about innovation diffusion. The innovation diffusion is an important component of the AHRQ Falls Toolkit. You'll see it embedded when all of that discussion about unit-based champions is in place when you're looking at how to implement change. But innovation diffusion is the process of being able to communicate new ideas through different channels, certain channels through your healthcare system. Maybe there's changes you've been able to implement at a unit level. Maybe it's just on one shift, or maybe it's across multiple units. But how do you take these new ideas and get them adopted? How do you get them into the hands of people to be able to affect a change in practice? So that if you're trying to help adopt new ideas, that at some point in time in your implementation process, you have a sense of confidence that it's really being done as it's intended to be done, and you have reliability of the implementation process. How do you control for the confidence, the fidelity that something's really being done as it should be, and that it's being done reliably? Tough thing to do, because you have people who invent ideas, the innovators, you have people who are early adopters, and then all the way down the chain you've got people who resist change. So you always have to be thinking about how are you going forward with diffusion. The issue with Nancy Dixon and others on knowledge transfer is, how do you get people to share common knowledge, things that they all should be doing, and make sure that they have integrated this into their practice as well? What would an example of this be? We spent a lot of time in the Department of Veterans Affairs in our fall prevention program, and even on focusing on a single skill, like how do you assess for postural hypotension? Everybody should be doing that the same way. How do you get the competency of that one procedure to the hands and practice of every single provider? Again, that requires a lot of focused effort, and when you're trying to take knowledge, get that knowledge into the hands of everybody so that you can affect outcomes. Reduce falls that occur because of postural hypotension. It's a very classic example. And then, of course, evidence-based practice. And so when you're looking at the work of David Sackett and others, you know, we know what evidence-based practice is, but you know what, colleagues? Evidence is a moving target. And the essence of evidence evidence-based practice is that you have the conscientious use of the current best evidence in making decisions about care, considering individuals, patients' preferences and beliefs and their ethnicity when you're delivering healthcare practices and healthcare services. So evidence-based practice is really something that's very, very fluid. It's moving because one study could confirm or disconfirm a prior finding, and evidence is a moving target. So, colleagues, as you look on this slide, this is an algorithm that could fit any evidence-based practice model that you might be using. I'm at Tampa VA Medical Center, and we use the Iowa model here, but you may have another model that you're using. But the very first diamond that you see in this algorithm asks us, is the evidence strong enough to warrant a practice change? If the evidence is strong enough to warrant a practice change, that means that it's strong enough to know that if you do this, patient outcomes will be improved. So if that is indeed the case, then all of us have the responsibility for implementing that evidence-based practice into our practice, add to a policy and a procedure, helping to make sure that it's really being done. So even though you put in a policy and a procedure, then you still have to get it into the hands of people. That's the knowledge transfer piece, and that's also the innovation diffusion piece. If the evidence is not strong enough to warrant a practice change, then it's our responsibility to be able to contribute to that body of knowledge, and that's how you follow the rest of the algorithm, whether it's doing quality improvement, program evaluation, or research. So much of what you've been doing over this period of time in implementing change hopefully has been done with the spirit of quality improvement, program evaluation. You have the measurement rigor. You've got outcomes you've been establishing so that when you do get to present the work you've been doing February to April, you'll be able to show how you change structure and process to be able to affect outcomes. There's some wonderful guidelines that are out there called the Squire Guidelines in helping you be able to publish the work that you've been doing. And they actually just got updated. Squire 2.0 just came out in September. And the lead author of that guideline, his name is Greg Orgren, which is really fun because he used to be a patient safety fellow with us in the VA working with Julie Neely, again, who's on the call. Let me just briefly say as we go forward that in my hospital we use two different grading scales, and everybody should be using grading scales when you're doing evidence-based practice. And I'll explain to you briefly why we're going over this, because there's been many questions that Michelle has forwarded to us, the faculty that have been part of this project with you, and asking us, when you have said, where is the body of evidence? Where is the level of evidence? So let's go over this. I'm going to share with you again the two that we use. So, and you probably are familiar with the Agency for Healthcare Research and Quality's grading scale. But that helps you grade the level of scientific rigor. So what you're looking at is the evidence first. You look to see, has there been a meta-analysis that's been done where you've done everything that's out there, and you have inclusion and exclusion criteria, all the randomized controlled trials. You see what meets your inclusion criteria, what can be included, what is excluded, and you see, does the findings confirm themselves? So meta-analysis can only be done if there's enough evidence that's already been published. Come on down to a level 2. This is a randomized controlled trial. So this is where you're holding all things constant and testing an intervention. So you have a control group and you have an intervention group. This is something that you've probably read, Dr. Patricia Dyke's work, randomized controlled trial on the intervention that she implemented with patient engagement for individualizing fall prevention plans of care, published in 2010. That's a randomized controlled trial. You hold all things constant and you go ahead and you test the effectiveness of an intervention. We don't have a whole lot of randomized controlled trials that have been done in hospitals on fall prevention back to 1999. There's only maybe 20 studies that have actually been done that are randomized controlled trials. You come down to quasi-experimental studies, and then you see the rest of them. So a lot of what is being done in healthcare for fall prevention is based on clinical expertise, which is a level of evidence, but it's level 5. It's the lowest level of evidence. So something that you're doing today, and you looked at the literature, there's nothing that's been published because we don't have a piece of literature to support every clinical decision we make. We make decisions all the time because we're clinical experts. That is a level of evidence. That's level 5. So you want to be able to know the level of evidence that supports, includes something in your practice, that of your staff in today's world. And then when you evaluate, has that level of evidence changed because the body of knowledge has changed in the next 2 years? Whenever you evaluate your policies or procedures again, you want to look to see, has the level of evidence risen? Has it moved on up the ladder, if you will? So again, a lot of what we have implemented in relationship to fall prevention, for example, universal fall precautions, you're going to find a randomized controlled trial that tells you you need to have effective lighting. You're not going to find a randomized controlled trial that tells you should put non-skid socks on some patients, but not all. There are some things that you're not going to find literature for. There are things that we know are important because of clinical judgment. So there's one level of evidence when you're trying to look at grading the level of scientific rigor. The second rating scale that we have, that we use, is from the United States Preventive Services Task Force. And this is the grading scale that helps you to know the evidence is tried and true, that that if you implement this, the outcomes will be improved. And that would be grade A evidence, where it's strongly recommended that we should integrate this into our practice. So in my hospital at the Tampa VA, we actually built a competency around grade A evidence for our nursing staff so that everybody knows what grade A evidence means. This means that the evidence is tried and true. We should all be doing this because if we do, patient outcomes will be improved. So it might be an example of that in relationship to fall prevention. Single intervention, an example, would be exercise. Everybody should be exercising, but if you look at all the studies that have been done for exercise interventions, all over the place in terms of dose, intensity, duration, the populations that are included in the studies. So, but they're all, they're all varied. But the point is, they still show benefit and patient outcomes. So yeah, we try and always help patients to know that they need to be exercising, to move. What was an example of level B where it's looking pretty good, the evidence is looking pretty good, we should at least be recommending this to people? Well, for fall prevention in older people, the example of this would be vitamin D, that we should be increasing the vitamin D levels of our older adults. The controversy is the dosage. So this is where you start looking at how to use this rating scale. So let me briefly just emphasize for you the difference between C and D. Level C is in the face of insufficient or conflicting or emerging evidence, you're going to make a decision to implement this into practice because you think that there's more benefit than harm. If there was ever more harm than benefit, then when you start moving into level D. So level D is where you have a recommendation against this. So let's talk through this just very briefly. One of the things we're going to talk about today is intentional rounding. And you have a lot of questions about intentional rounding, purposeful rounding. Well, if you go back and look at the AHRQ Toolkit and you look at the inclusion of hourly rounding, intentional rounding in the AHRQ Toolkit in Chapter 3, what you would find if you looked at the references to support that intervention, it's not a best practice, but it's included in there. But it's included because there's expert opinion that it should be done. It's not because there's randomized controlled trials if you went back to the prior slide. But looked at the references to support that inclusion in the AHRQ Toolkit based on a 2009 review article by Margot Halm out of Salem, Oregon. It was a review article. And another article, a second article, that actually looked at implementation barriers. It was an article in 2012 that looked at how hard it is to implement it. So again, it was included in the AHRQ Toolkit because clinical experts said it should be, but it was included in the AHRQ Toolkit as something that should be done because we know it has value. It's not because it was done because there was a whole lot of evidence at that point in time. So it's always important, colleagues, whenever you're looking at any intervention that you're implementing, that you go ahead and make sure you understand, the level of evidence in relationship to what it is that you're trying to implement. So in the AHRQ Toolkit, the best practices that you want to look at that was actually included in this AHRQ Toolkit, in terms of best practice, that best practice refers to, there's two definitions for it, is that it's a standard way of developing, implementing, and sustaining a hospital fall prevention program. And there are those care practices that, based on the literature and expert opinion, represent the best way of trying to prevent falls. So I want you to help appreciate that it's not because everything is based on a meta-analysis and everything is based on a randomized controlled trial. It's what people came together, the experts, the people that reviewed the literature, the experts that came together and said, this is something that should be included. And I remember clearly, Julia will remember this too, and I think Kate was there, when we said, you've got to put post-fall huddles in the AHRQ Toolkit. Even though there was never anything published, this is something that should be done. We've got expertise with it. So, everything that's in that toolkit, if you think about what's really a best practice, you think about that being based on the literature, but it's very different when you really appreciate the levels of evidence to support its inclusion. knowing how that evidence is a moving target. And if you find something that you think is really working, then hold yourselves to the same standard of rigor where you actually conduct quality improvement program evaluation with that level of rigor, that you can actually publish the work that you've been doing to be able to show it has been effective in your setting of care. So that being said, we've talked about the level of evidence to set the stage, and talked about what's the best practice in relationship to what was defined and included in the AHRQ Toolkit, the Fall Prevention Toolkit. But we'll talk about a report that came out in 2013. The second report on making healthcare safer that was published, and you can see the authors of this. Some of you will remember in 2001 the report that came out after the 1999 report to Error is Human. In 2001, there was a vast amount of knowledge that did exist on patient safety practices, but not a whole lot of evidence. So since 2001, there has been so much more that's been published on patient safety practices. And the second report, 2013, they now have agreement on what constitutes evidence of effectiveness. So they have refined what we should all be looking at if we're saying something is effective or not. They've also included the importance of implementation, which is really relevant to the work that you've been doing, because rarely in any patient safety work do people keep track of the implementation process. If you're doing plan change theory, do you keep track of every PDSA cycle to change something based on having a period of time to step back and say, what worked, what didn't work, what did we change as a result of that, so we can do the next iterative process to reduce barriers and enhance facilitators so we can get something adopted? And how easy was it to get something implemented? What were the barriers and facilitators? So this whole focus on implementation science has real relevance in this 2013 report. And that's the work you've been doing too. We do lots of work with this and breakthrough series and collaborative works that we do with all different entities throughout the entire country and the VA. The other thing that was added in the 2013 report is context. And this is essential too, because in patient safety practices, especially for falls, when you look at one of the chapters in this report, chapter 19, which is on falls, there's only one article at all that has addressed context of implementing change for patient safety and hospital fall prevention across facilities. And that was a project that Julie Neely led, and you would find her article, I was a co-author with her, that's in there that addresses context, only one. So is that important? Because how you implement change, how you adopt something, even get something trialed on a day shift is going to be very different than how you do it on the night shift. The context is different. The staffing is different. The patient care needs are different. How you roll something out on a med-surg unit is going to be very different than how you roll it out on an ICU or a rehab unit. Context is different. Rarely in any of the patient safety practices and the work that they're doing do they even begin to discuss or consider the importance of context. So see here in the AHRQ 2013 report, Making Healthcare Safer too, the definitions that they use on the evidence of effectiveness. Did you have a low level of evidence of effectiveness? Was it moderate or was it high? There's very little on fall prevention that has a high level of effectiveness in terms of measurement. And even a very little discussion on benefits that outweigh harm. When bed alarms, which we'll talk about, I'll be able to give you an example of this. Or the potential for being able to implement something and what might be the unintentional consequences, like all of the issues with bed alarms and all the false positives that ended up being the alarms going off, and you have all these nurses responding to these false alarms going off, unintended consequences. You really hear anything about cost, how much what did it cost to be able to implement this kind of intervention, and how much do you want to invest, and that gets into your return on investment. And then, of course, the implementation issues. How easy was it for someone to be able to implement it? Could you make a toolkit out of the work that you're doing? So when you're looking at the scope of patient risk, there's been so much effort and attention that's been focused on reducing hospital adverse conditions, especially patient falls with injury. And even though this is the case, in hospitals, falls remain the top reported adverse event, and people are still getting injured. So I am so thankful to this project, the AHRQ project, because it's helping us all step up our game and have more precision in the work that we're doing. And we know you're going to be sharing success stories so that you can continue to spread solutions. But hopefully are moving away from a score on a scale or a level of fall risk And we want to talk to you about the Joint Commission's National Sentinel Alert that just came out September 28th. Because the Joint Commission has been collecting data on statistics on falls. And they've done this for years, and they're voluntary reporting, so they're not going to have all of these. But you know, they still get, some of the falls sentinel alerts, and they're not the only accreditation agency for hospitals in this great country. But nonetheless, you'll see the data that's there. And the sentinel alerts that are going to the Joint Commission are not coming down. So we know that this is still occurring. And they're still falling in our care, and they're still getting injured. So in this sentinel alert, well, it is known that the most common contributing factors that pertain to the risks surrounding falls occurring is that we have inadequate assessment. Because what happens is people focus on a level of fall risk and not actually assessing patients or only screening people. We have lots of communication failures where the patient falls in our care and it doesn't even get handed off to the next unit that might be taking this patient or the next setting of care. There's lots of issues with lack of adherence to protocols or safety practices. And this, becomes a real problem for all of us when we're trying to make sure that things are reliably being done. Staff orientation, education, supervision, skill mix is a huge issue. You just can't teach staff annually about fall prevention and think it's going to be sufficient. And an example that I give of that is if I walk onto a rehab unit and I ask the nursing staff who's more at risk for falls, a left brain CVA or a right brain CVA, they should be able to tell me that it's the right brain CVA. You just have to help really focus on clinical competencies. And the same thing with supervision is how do you make sure, how does an RN who's delegating to a nursing assistant or a patient care technician to check for postural hypotension that they're doing it right, or even that the nursing staff is doing it right before they make this delegation. And then we know the issues surrounding staffing and skill mix. This is an important component as well when you're trying to look at implementing any kind of a patient safety practices. There's lots of issues in our physical environment that contribute to falls as well as injury risk, and then the importance of leadership. And the lack of leadership really resonated in the AHRQ report, the AHRQ Falls Toolkit, because that was the whole focus of Chapter 1, as you got to hear, is getting leadership on board when you're trying to help implement a patient safety program. So there are these domains that actually came out of the Sentinel Alert. The Department of Veterans Affairs, through the voice of Dr. Robin Hemphill, the director of the National Center for Patient Safety, she helped Billy Neely and I to have voice on this Sentinel Alert before it got published. So these are what was suggested that came out, again, September 28th. Is all organizations, they should lead an effort to raise awareness of the need to prevent falls resulting in injury. And this is important to all of you to hear, that this is not just about falls. They're making sure that patients, if they fall in our care, are not getting injured. And that goes back to the Partnership for Patients Hospital Engagement work. When they looked at the 9 hospital-acquired conditions that we really wanted to go after, it was falls with injury. It was not falls. Because you can't look at all falls as if they're the same. There's different types of falls, as you've heard. Everybody should be focusing on this injury reduction because people are getting injured. 30 to 51% of the patients who fall in our care get injured. That's in the literature. Across the world, it's in the literature. So we have to do something different to protect people because they're going to fall in our care. It happens. And so that's Mythbuster number 1, helping us get to injury reduction. Secondly, all of us should be establishing an interdisciplinary fall injury prevention team. Evaluate the membership and the team in place. So gone are the days for a fall prevention program to be nurse-managed, nurse-led, nurse-everything. It just doesn't work. And the interdisciplinary team has to be on board and have to help with injury reduction. It's not just fall prevention. And that everybody should be using in today's world a standard validated tool for identifying fall risk factors. So this is going beyond homegrown tools. No one in today's world should be using a homegrown tool for fall risk screening. I don't know anyone who isn't using the Braide scale, for example, for pressure ulcer risk. And there are still hospitals, I'm telling you that there are, that are still using a homegrown tool. So gone are those days. So when you're looking at this, this means that in this third component of the Sentinel Alert is it's really focused on getting to actual fall risk factors of a patient and also their injury risk. So when you read the alert and you get into number 3, the Joint Commission is very clear now. This is not about a score. It's not about a level of fall risk, low, moderate, or high. It is about identifying individual risk factors, waking people up to see what's modifiable, and treating those that are modifiable, helping people compensate for those that are not, and also making sure that all patients who come into our care are also assessed for injury risk factors. So it's fall and injury risk. And that's the work that we've been doing in the VA since 2008. That's the work that we were able to help influence with the Agency for Healthcare Research and Quality in the Falls Toolkit. That's in the toolkit. It's in chapter number 3. And also the Institute for Healthcare Improvements Toolkit on transforming care at the bedside. Then fourth is that everybody should be moving into individualizing plans of care, which I know is going to be a great presentation that you got to get your Dr. Dykes to be able to present to you, that being able to really go after individual fall risk factors and get them treated so that the measure of our success should be the patient actually had their risk factors reduced, mitigated, or eliminated because they were in our care. It's not whether or not they fell. It's because we made them better off. We did their urinary tract infection. We modified their postural hypotension. We helped them compensate for their sensory neuropathy. The other important component of number 4 is that this also gets into a population-specific approach to fall prevention. For example, the ABCS. What do you do differently for people over the age of 85, people at risk for fracture, people at risk for bleeding? That's people who will stop. The last 2 components of the Sentinel Alert is everybody should be standardizing and applying interventions that are demonstrated to be effective, and this is how you do handoff. When you do handoff, you just don't talk about some being at risk for falls. You talk about why they are, and you talk about what are we doing because of the risk factors, where has the plan of care changed, and then doing one-on-one education with patients so that they understand why they're at risk for falls, what are their fall risk factors, what are we doing about each one of them, and then tell you that back. It's not just putting an armband on someone because they're high fall risk, but helping them to know why they're at risk for falls and helping them teach back. So we use a lot of teach back in the VA and helping them to teach us back why they're at risk for falls and what are they going to do to be able to prevent this. And then, of course, post-fall management. And why is post-fall management important? Because we're only doing this because someone fell in our care. If someone didn't fall in our care, we would not be doing this. But what they include in the Sentinel Alert with our input is to do the post-fall huddle, to try to figure out why someone fell, what was the reason for that fall, what type of fall that occurred, why they got injured, was it preventable or not, because we have a whole preventability component included in it. And then also the system, having a system of honest, transparent reporting. So it's not about numbers. It's about knowing why people are falling and then making sure that the patient is included in it and they are able to be engaged in trying to prevent it from occurring again because they learned because they were part of the post-fall huddle process. And then the trend, reasons why people are falling. So this gets into the analysis, and then you do continued assessment. So we really hope that every one of you has had a chance to be able to read this alert. September 28th. It was going to come out on National Falls Awareness Day, but it was just a little late. So we have a 3-pronged approach in the Department of Veterans Affairs in helping to reduce falls and fall injuries in our care, and have done this for years. And all of us have been doing fall prevention for a long time. But our assumption is anybody could fall any time in our care. You can't prevent them all. But what we just don't want is anyone to die. That's R0. We don't want anyone to die from a fall. Number 2, we don't want people to break hips. Because the patient population different from yours, except one of your participating hospitals is a VA. We just want people, we don't want people to break a bone because ours is an adult population, predominantly men. So we're all about protecting people. If they were to fall in our care, we don't want them to get injured. So injury reduction is separate and distinct from fall prevention. Because your fall prevention strategies have to be different if you're reducing accidental falls versus anticipated physiological falls versus unanticipated physiological falls, which you cannot prevent. So we go after reducing preventable falls by a certain percent in a year. That's always our goal that we do in terms of our goal setting. So going after 2 types of falls, accidental, anticipated physiological falls. So I knew you got into those in Chapter 3. Protect people from injury, and then, of course, surveillance. How do you make sure that you're checking on people without having to use all these bed alarms? So we have this 3-pronged approach to the work that we've been able to do. I just wanted you to see that for years on this slide, how we as the VA went way beyond these screening scales. We used the Morse scale almost exclusively throughout the entire VA, but we also embedded the AGS guidelines, the American Geriatric Society guidelines, into our national templates. So you'll see here, if someone says yes to the very first screening question on the Moore scale, history of falls, how our template opens up. And you could just keep on going. I could walk you through this template. I just don't have time today. But if they said yes to a history of falls, look at the template, how it opens up. The nurse has to ask about the falls. You know, why are you falling? What's going on? You know, how many falls have you had? Are you falling inside or outside? Do you fall because you stand up and you get dizzy? That's the fall history. And then look at the second question that we embedded into our template colleagues. If someone tells us that they've fallen, what do you see next? We're going to ask about their fall injury history. For years, we have been asking all of our veterans who come to our care about their fall history as well as their injury history. They'd say yes to an injury with a fracture, and then it would open up again, and we'd see wrist, arm, or hip. They also say yes to an injury without a fracture, and then we'd start getting into lacerations and hematomas. So it just keeps going. But what's my point? Is that we, before the Sentinel Alert, we were integrating fall risk with injury risk into all of our admission assessment processes. And this is really where you want to be able to go. So let's talk about some of the interventions that many people have been implemented, and how did this happen? Well, bed alarms. Well, we've all known that bed alarms don't prevent falls. And how it happened that bed alarms started getting added into policies in hospitals for people who are high fall risk, because that's almost our entire inpatient population in the VA. But bed alarms, you know, evidence is clear, they don't prevent falls. It's the Ron Shore article, and I know you've seen it. And they were designed to prevent falls. They were designed to be an early warning system. So when you start looking at how this got done and how it got implemented into policy, every one of you should know what level of evidence was this included into your policy or your procedure, because before the Ronald Shore article, there was very little literature that was out there. What would be the appropriate use for a bed alarm? The appropriate use for the bed alarm, if this was to be part of your toolkit for helping with surveillance and detection, to get to someone before they got up, that was a true positive. They were really trying to get up. This isn't a false alarm. With people with cognitive impairment that we know are able to get up, and they're trying to get up, and they fail your teach-back strategy. So these are people that you worry about. They cannot be a full partner in your fall prevention program, and they're going to try and get up without you. So those might be patients that you would include in the bed alarm. So the bed alarm is a huge opportunity to reevaluate a practice that we're doing, and it should not be universally applied to all patients just because of a screening scale. When you look at fall-related outcomes that are not improved, this would be the example. When you look at the Shore article published, even there was no significant difference between the pre and post differences in relationship to change of fall rates, the number of patients who fell, the injurious fall rates, the number of patients who were physically restrained. You have to appreciate that this is a cluster randomized controlled trial. So that then starts getting into, do you know the study design? And they want to look at, to be able to test the effectiveness and statistically use a risk ratio. Their risk ratio was to compare the rate of falls on the intervention group with the falls that were on the control group. So if the 1.09, if you look at that, if the number was below 1.00, then that would mean the results were favoring the intervention group, that the intervention group was being protective. But we see here in the statistical significance is that the intervention group actually had more falls overall than the intervention group. So this is an increased risk. It may not be statistically significant, but this is an increase in risk. So that's what you end up having to read in the article and going beyond just what is summarized in the results of the study when they say that overall there's no change in fall rates. Not true when you look at the actual statistic. And bed alarms, you know, it was actually asserted that it was intuitive, like bed rails and restraints, that they are not effective, but it's even worse that they may cause harm. So that's why when the Ronald Shore article came out, and where does the may cause harm come into consideration is when you go back to that rating scale and you now start getting to level D, was where there may be more harm than benefit, and it's going to create opportunity to pause and reconsider why are you doing what you're doing. So in this bed alarm study, Ronald Shore, he was so ready for this result to be, when it was published, for the backlash that would come from the healthcare industry, because everybody had it in their policies and procedures for high fall risk to be putting bed alarms on all these people, even people who are cognitively intact. And saw this, so it created a lot of pause in the industry, and people pulled back. And you can Google in long-term care settings, there are chains and chains of long-term care settings that have eliminated bed alarm usage, and fall rates aren't going up. You know, this is an opportunity to evaluate technology. So when you look at all the technology with bed alarms, and you'll see many of them that are here, oftentimes in hospitals they will use one piece of technology and think it's going to work for everyone. And that's the same problem that we've been using universal fall precaution alone. It doesn't work. So, colleagues, there's so much opportunity to contribute to the body of knowledge when you're trying to determine what do you want staff to spend their time doing that you think is going to improve patient outcomes, and come back and reevaluate things that we're doing that really just do not have the bang for the buck. And now you have evidence that, even though evidence is a moving target, that confirms what we've all been saying: bed alarms don't prevent falls. The same thing with bed rails. Bed rails should never, ever be used for fall prevention. Never, ever, ever. And bed rails, this dates back to the 1980s. In long-term care. And you have to remember, when you look at the evidence surrounding fall prevention, the studies in long-term care outdate. They go way back before any studies done in hospitals. Fall prevention in hospitals really did not gain national momentum until about 2000, and even by the Joint Commission until 2004, 2006, when it became a patient safety goal. It didn't have prominence. But when you look at in the VA, it did, because falls became the #1 adverse event after we implemented BARC medication administration. So we've been working on this since the 1990s. But the bed rail reduction component really focused on the work by Liz Capizzuti that dates back to the 1980s in long-term care, and we knew that if patients fell from a bed with a bed rail up, they had more serious injuries because they climb over the bed rail, which makes them fall greater distance, and they have more serious injury. Or even worse, they could be entrapped between the bed mattress and the bed rail, because hospitals don't replace the bed frame, but they replace mattresses, and then you have a gap between the rail and the mattress.
Thank you for calling HCA's Far West Division and Far Transfer
someone
Center.
Just put us on
serving
hold.
the health needs of Las Vegas,
Here, can you
San
please
Jose,
mute that line?
Thousand
Las
Oaks,
Vegas.
West Hills, and Riverside communities. Please.
So if you're using bed rails, thank you, Michelle. So if you're using bed rails, they should be used as a mobility aid, but never to prevent falls. But what might be the appropriate use of a bed rail? It's for a mobility aid, or if they've got some of the technology actually integrated into the bed rail. So you're always reconsidering why you're doing what you're doing. Into the surveillance systems, there's such wonderful emerging technology that's very, very exciting. So it is great to be able to keep up with new and emerging technology when you're trying to do the surveillance that moves you away from these bed alarms. We're really looking at the CareView and the AVASys as having momentum in the VA, and lots of other healthcare systems beyond the VA have this camera surveillance systems. Ambulatory aids for people with Parkinson's, a laser light system that helps them to be able to walk, and of course different kinds of mobility and wandering technology that's out there. What you ask is, can you describe how the camera surveillance system gets instituted? Well, the camera surveillance system is real-time surveillance where you have someone watching people. It's non-invasive. You're watching someone. There's one system, the AVASys system, AVASure, where you can actually talk to the patient. You would have a little worry about talking to someone with cognitive impairment, but nonetheless, you can ask someone what they're doing, and if they need help, and tell them help is on the way. But it's able to detect because you're actually watching someone, which is very different than the bed alarms, because bed alarm goes off. By the time you get there, someone's already found down. So this is real-time surveillance, and the healthcare systems that are using the camera technology, they've eliminated their bed alarms, they're reducing sitters, and they're preventing falls. And all the money that they're saving with reducing sitters alone, and then reducing the burden of falls that occur, is able to have your return on investment be able to pay for the equipment. So the camera surveillance system is a detection system because you can watch someone, and it's not for everybody. So who would you be watching? The people who a sitter is very agitating, which would have been like my mother, or people that you just you don't want to put the bed alarm on because they're going to be afraid. Someone who's cognitively impaired and confused and can get up, and the bed alarm's going off, and they think it's a fire alarm. So that's being able to expand your toolkit. For people with detox and impulsivity, what are some of the triggers for getting a sitter? Are any sitters for the sitter? If you're going to use a sitter for this kind of a patient, the sitter should be paying attention, and the sitter should be able to be within arm's reach always. So that if someone is trying to get up, they would be able to be there, and if the patient does start to fall, then you would have an assisted fall. What you want to teach the sitter is to make sure with an assisted fall that they protect the head on the way down, never protect the whole body, but protect the head. If they're protecting the whole body and lowering the body to the ground, and you have someone that's being impulsive, someone who is agitated, then you could have the sitter getting injured. So the balancing measure of a sitter effectiveness would be staff injuries. You don't want them getting injured. And so the actual measure of effectiveness of a sitter would be severity of injury during that fall, not the fall, because a sitter cannot prevent all falls. And that was upheld in the 2014 report that came out of the Pennsylvania Patient Safety Authority in 2014. Evidence for intentional rounding and the surveillance method, evidence is emerging is what I will say to you. Again, like I mentioned in terms of the AHRQ report, if you look at there's two articles that supported it being included in the AHRQ Toolkit, and it was 2009 and 2012. I shared with Michelle and others, and I know that got sent to you, an updated evidence review in 2014 that was published out of the UK. But when you look at the evidence surrounding intentional rounding, the problem with all of this intentional rounding is intentional rounding was originally designed to improve patient satisfaction. It was not designed to prevent falls. So when you look at the evidence, you have to be very clear about what you're looking at. This is a 2014 article that I sent out to Michelle and Toria. And if you look at this, the nurses currently using the 4 Ps. There's still variations across all of the articles on what they're doing. There's only 20 articles that were found since 2009, and you can see where the studies were. 9 research studies, 8 of them in the U.S., 1 in Australia. But they focused on patient outcomes and staff perceptions. But the studies that were done in the UK, none of them, they were quality improvement program evaluation. None of them actually went to an actual IRB for approval. But when you look at the results, there was a 36% decrease in the monthly average of low-consequence patient falls. That was one article, but look at it. This is all falls. You can't say that. Even with purposeful rounding, which type of fall could you prevent? If maybe, could prevent accidental falls if you went ahead and there was no slip or trip hazards, or maybe you got them to the toilet before, while you were doing the rounding. But you can't get all falls because, remember, there's some that's preventable. And then we all know the Meade article, that was the historic foundational article where they looked at a 50% decrease in falls. But again, this being able to look at all falls as if they're the same, and that's where you lack precision, but they didn't control for implementation. That's the issue. They didn't actually were able to verify that this was actually being done. And the U.S. study showed no significant effect in the incidence of falls with intentional roundings that were conducted for every 2 hours, but they had more effect in the ones that were done for every hour. But then I all know that intentional rounding isn't done 24/7. Every hospital, every unit goes ahead and modifies how is this being done because context occurs. So that's why when you start looking at all the studies that have been done, they lack so much methodological rigor in terms of implementation. How was it done? Was it done as it was intended, and was it reliably done? This is fidelity and reliability. So much of the research is fragmented. It focuses on clinical outcomes, and there's no data to be able to compare this with other nursing approaches. You will find this in the 2014. So my advice, this is Pat's advice, which is I wrote here. When you look at rounding, if you're trying to prevent falls, to me, then this is going to be the preventable falls. This anticipated physiological falls. Let's be precise. People who need to be on scheduled toileting, people who need assistance to get to the bathroom, or people who are on bladder retraining, a stroke patient who needs to be on a bladder retraining program, that should be hardwired. People know, is this patient to be taken to the bathroom on the even hour or the odd hour? They should know that. That should be part of a plan, and that should be hardwired. Because we all know patients get up to go to the bathroom without us. It's probably the number one reason why people are falling getting up out of bed. They're getting up out of bed out of a low bed, and they're trying to get to the bathroom. So this is something that should be done. Or if you're giving someone pain medication, is to get them toileted before this pain medication. And they have to also think about pre-shift huddles, where you identify those who need toileting more than every hour. And who is this patient? This is an 85-year-old who got admitted with congestive heart failure who's on a diuretic. If you think doing hourly rounding for toileting with this patient once the starter kicks in is going to be effective, then we all know different. So we'll be doing a pre-shift huddle to identify those patients who we all need to help get to the bathroom more frequently for a certain period of time, like my 85-year-old female got admitted with congestive heart failure and is now on a diuretic. So this is clinical practice. This is common knowledge that we all have as expert nurses on how to be able to provide care. That is the reason of rounding. Some of your questions. So it's going into injury reduction. You know, it is protecting people from injury because that's the moral imperative. So hopefully some of you have been looking at injury reduction strategies because, after all, that's the adverse event we're really going after. And that's going to be the focus of the Sentinel Alert from the Joint Commission, but it always was the focus of the adverse condition, the hospital-acquired condition for the Partnership for Patients. So we're implementing floor mats. I don't know how many of you maybe trialed this, and floor mats are one of the interventions we've been doing and implementing for years in the VA to reduce injury if someone falls from our beds, because we know what happens. And the floor mats, I'm telling you, they work. You can't implement rubberized flooring everywhere. Anyone who's using floor mats should be making sure that they have beveled edges and not having the one like you see in the center where you step onto it. But there are floor mats that have glow-in-the-dark strips on it so people can see when they're down at night, but they're only down at the bedside when someone is resting in bed because they were designed to reduce trauma if someone falls out of bed. And it's not for everyone. You don't need a floor mat for Pat Quigley, who's cognitively alert and functionally independent and needs to be in a height-adjusted bed for me because I'm 6 foot tall. So again, it comes back to being able to really individualize plans of care. But on the VA's Patient Safety website, the National Falls Toolkit, we have a whole listing of floor mats that are beveled edges, different dimensions in terms of length and width. So you want to protect the head and the torso. You don't want to protect the feet. And we conducted research that was published in 2008, colleagues, 7 years ago, that actually shows a compelling reduction in injury risk, severe injury risk if you had a floor mat down. So if you had someone fall from a bed onto a floor without protective flooring, from a normal height bed over the bed rail, this is the bed rail issue, you have about a 40% chance of a serious head injury. Whereas if they fall from a low bed onto a floor mat, you reduce that risk by 39%. So it's absolutely compelling how protective these floor mats are. So you have to look at, what are we doing to help really protect people? And we have a technology resource guide. I've had it for years on selecting floor mats. And then again, of course, the listing that's on the National Center for Patient Safety. And it's not just undergarments. They have clothing. So even if your organization is not providing this, you should at least be letting older people who have risk factors for osteoporosis or hip fracture already know about hip protectors because they've been around for a while and they reduce the amount of trauma that makes it to the bone. Just like floor mats reduces the amount of trauma that's sustained if someone falls onto a hard surface. So rolling out floor mats on a national level since 2004, we have over 10 years of experience in doing this, and we even have a toolkit. The toolkits are designed when you have enough evidence that you help to standardize practice. So let's look at some of your questions related to the effectiveness of hip savers, hip protectors. Absolutely. We did the same thing with hip protector testing. When you looked at the hip protectors that I just showed you here besides the floor mats, we actually did the impact testing of hip protectors just like floor mats, but we did it in a lab. We did not do it with a patient. The issue with hip protectors is that people want to have their hips padded, and it's not just women, it's men too. But they do work, and if you in the VA, we've been giving them out since 2004, as I mentioned, over 10 years. But in Canada, they have a huge social marketing campaign for older adults because hip protectors absolutely reduce the amount of trauma that makes it to the bone. But you cannot look at patient-specific studies. You have to look at laboratory-based studies because any of the studies that were published that looked at effectiveness with patients, any of the trials didn't control for adherence, and they did not control for the protective nature of hip protectors. So it's bad science that got published. What does research show about using the posy beds as a fall prevention strategy? Posy beds, just like any bed, does work, but it's the height of the bed that you need to look at. You cannot keep people in a low bed because if you're just having people in a low bed all the time increases their risk for falling because they can't get up from it. So you need to have beds that are height adjusted, and everyone should know the height that you have my bed kept at, because I'm 6 foot tall versus someone who's 5 foot tall. Suggestions for keeping items close to people, absolutely they should be. They should be kept close, especially mobility aids. The bedside tables, the bedside table should be on the side of the bed that someone does not get out of. If you want to create a safe exit side where people getting out of the bed towards the side that is their stronger side or the unaffected side, that would be the side you'd put the floor mat down, so you don't have to have the patient have floor matted on both sides of the bed. But the mats, remember, are only down when a patient's resting in bed. So if you're providing any care for a patient or the patient materials, it should be on the other side of the bed. And when you're providing care, you move the floor mat underneath the bed or put it away in the shower that no one's using. Working with patients with sequential compression devices to prevent falls. They should not be on patients with cognitive impairment. Those are patients where they should be contraindicated. You have TED hose on those patients. There should be exclusion criteria for these sequential compression devices. People need to be educated about the risk of them and why they can increase risk for falls, and they should be able to teach you back and tell you why they make it their risk for falls and what they're going to do when these are on to make sure they get help before they get up. You don't want people getting up with these on. So the ABCS, this is your population-based approach to injury reduction. This is what brought the Institute for Healthcare Improvement to us, to identify at least 4 populations that we know if they fall one more time, that could be it. This is included in the Joint Commission's toolkit. They did not specifically say ABCS, but they did include a population-based approach to injury reduction. In the VA, Julie and I have developed with Dr. Keeson across the country an implementation guide for implementing this throughout the VA. What do you do differently for people over the age of 85? Because one more fall could be it. What do you do differently for people that you know are at risk for fracture? You've got to get them into hip protectors, get them worked up for osteoporosis, and look at the floor mats. What do you do differently for people who are anticoagulated? Because no matter where they are and they fall, they're going to bleed out. And what do you do for people who are post-op? So you have to really look at this. For mental health units, oh my gosh, they're so challenging. Believe me, I know. And you have to consider psychiatry, the culture of psychiatry units, because colleagues, we all know that their primary focus is to deal with their behavior issues, their psychoses, and all of that rises to a level of urgency. So, in relationship to fall prevention, what you want to be able to help them is to help falls rise to a level of importance, because there's lots of things that can be done in psychiatry. Looking at the Unit Peer Leader program, and that's embedded in the AHRQ Toolkit, the Unit-Based Champions. Help to get people to review medications to see can they be modified in any way to reduce their fall risk while still managing their mental health needs and their comorbidities. And then in handoff, you want to talk about fall risks, interventions. People need to be worked up for postural hypotension in psychiatry. So many of the medications that they're taking, this is a known side effect. And I'm looking at gaps in technology where you can work with the vendors, because I will tell you, we found ways to be able to bring in wedges that could be used to elevate the head of beds on platform beds, looking at new floor mats that we could use, even with toileting, having people do scheduled toileting, raised toilet seats that you could use under supervision. There are things that can be done, but if you have someone who's actually acting out and you think that they're falling because of behavioral issues, the way we dealt with that is what we call an intentional fall, and we actually subsumed that back up into anticipated physiological falls. Behavioral falls, if it is really acting out, the way you would come up with a behavioral fall is the root cause is if you said that all other reasons were ruled out. They didn't have a change in medication, they didn't fall because their pajama pants were too long and they slipped on a leg, and we ruled everything else out and it was only behavior. Well, then we call an urgent team meeting, because the nursing staff should not have to deal with this alone. And I'm a rehab nurse of 100 years. On rehab, you could always call an urgent or emergent team meeting. You might not be able to call them the same shift, but you call it as soon as you can. So that you get the team on board to come and help deal with that patient. So what are your issues? Falls are often related to psychiatry issues and detox. So what are the top things you can do? You can, do anything you can to help calm them. But for some people, you put the mattress on the floor. That's absolutely okay. Do that. Especially in detox and substance abuse, is to do everything you can to prevent the fall. But remember, for these patients, you cannot prevent all falls. You just don't want them to get injured. So everything you can to pad up the environment, get rid of sharp edges. Even some of the platform beds, pad up those corners. And what are other hospitals doing with alcohol withdrawal or delirium? They're doing everything they can to implement the delirium detection management toolkit. And we have a great resource in the VA, Jim Rudolph's work on delirium detection and prevention. It's a whole toolbox, a toolkit that you can access online as public domain. But to be able to help anticipate behavioral issues, doing your scheduled toileting, doing everything you can to keep a calm and routine environment. And then for people with dementia, it's the same thing with them. These patients cannot be a full partner in your fall prevention program, so you have to anticipate their needs, you have to calm them, and you have to do your scheduled toileting before any pain medication, toileting after they've had meals, and then getting some routine going. Because even people with dementia, remember there's a wide range of severity. So with dementia, there are people who can learn because of procedural knowledge, and there's people that are so severely impaired that you just have to keep them safe, keep them safe, keep them safe. In terms of the post-fall huddle, how do you synthesize data for a post-fall huddle? The post-huddle is only done because someone fell in your care. So you should be able to collect data on post-fall huddles about why people are falling in your care, and that's your proximal cause. So you should be able to trend that. That's what we need to know is why are people falling in your care. And because you know why people are falling in your care, you should be able to know the type of fall that just happened. So you'll be able to tell any of us, are 80% of your falls accidental falls or 80% of your falls anticipated physiological falls? If 80% of your falls are accidental falls, what are the root causes? What are your environmental issues? That's what you need to know. That's what you should get out of a post-fall huddle. And then to identify what are you doing to prevent someone from falling again because of the same reason. You have a patient who has two falls, two anticipated physiological fall, but you don't want people to fall because of the same reason. So one fall could be because of partial hypotension. We cut back their diuretic, gave them some fluid, get resolved. Second fall is because of urinary tract frequency and urgency, and they had too much stress and urgency, and they lost their balance on the way. It's anticipated physiological falls, but they're two different root causes. So you've got to get to the root causes. If you don't get to that, then you'll never know the effectiveness of your interventions. And you should have a change in the plan of care. So the reason why they fell, you have a change in the plan of care, and then you need to make sure that it gets implemented, because after all, colleagues, when someone falls in our care, this is not a paper exercise. This has to come alive. So to follow up and make sure that change in that plan of care gets implemented, the family, the patient should be involved always, always, always in the fall huddle, because it's only done with 3 or 4 people within 15 minutes of the fall event to get to the root cause. But if a family member is there, then they should be engaged in it too, because you want them to learn from it. You know, as a rehab nurse, I would rather someone fall in my care and learn from it than to go home alone and fall and not get rescued. So you want to always be helping to teach them and to prevent the repeat falls again. So that's the kind of data that you should be able to trend because of the post-fall huddle. In terms of structure and process, because remember in the work of quality improvement, implementation science, you measure structure and processes twice as much as you do outcomes. So in a post-fall huddle, you should be able to measure who came. Was it more than nursing? Did you have a change in the plan of care? What actions did you take in terms of process? How timely was it? How long did it take you to get that change in the plan of care, and how long did it take you to get it implemented? That's formative measures. And, of course, your summative measure, your outcome measure, would be preventing a repeat fall based on the same root cause, same type of fall. And you can show you're reducing the risks, the costs that are associated with falls and fall-related injuries. We want you to look for trends and targeted interventions. Go after preventable falls related to toileting. You know, the notification of this, observation of it. Falls to environmental issues. Are they doorways, shower stalls, long bedspreads? You know, and making sure that if you're making beds and you've got a safe exit side, that you put the longer sheet and the spread, the longer side on the other side they're not getting up out of. And then what are we doing with our handoff and shifts and days? You can always look at trends, but that's not going to get you anything. You want to really get to the reasons why people are falling. People collect so much data around falls, but they're not collecting data on root causes, and that's the post-fall huddle. So engage your staff. So what are some questions is how should hospitals be engaging physicians? I'm telling you, one of the best ways is to create an invitation. Just invite somebody. And, you know, you can't expect them to come to every meeting, but they want them to come at least quarterly when you're doing strategic planning, reviewing the data. And then you get past the point of view that this is a problem for just the nurses to answer call lights. It has to be owned by everybody, which is Chapter 1 of the AHRQ Toolkit, Implementing Change, Chapter 2. The second one here, how do you engage staff nurses in the value of fall risk assessment tools? By modeling. You have to help them be able to get to individualized care planning, and you have to go beyond the tool. You have to help them be able to know what are my fall risk factors and what are we doing about it compared to the next patient. That's what you have to help them do and role model that. And we've had some really great samples of nurse managers that have led that mission. Because you get into clinical competencies and helping people to know why is someone at risk for falls and what are we doing about it. And what's the best way to present data effectively? I believe in storyboards. Storyboards should be, what did we learn from a fall? What did we do about it? And let be the focus on leadership. That in your storyboards, this can be managed by the staff. Engage your shared governance. Have them control the storyboard. Because falls really, quite honestly, are relatively rare on a unit. Unless you're talking about a dementia unit or psychiatry, long-term care has a higher repeat fall rate. But in hospitals, they're relatively rare. So people should know, why are people falling in our care? I should be able to go onto a unit at any time. If there's someone who fell on my unit, staff should know who that person is. That rises to a level of importance because that's who gets the band or the falling star. Is someone who already fell on our unit or someone who got admitted because of a fall. Patient education, are there easy to read low literacy patient education materials? Absolutely. If you were to go to our website, the National Center for Falls Toolkit, and the VA, as well as mine, the Vision 8 one, you would find information here. And also CDC. The state program, Stopping Accidents, Elderly Accidents, Deaths, and Injury, has wonderful patient education materials there. Even teaching them about possible hypotension. They're really great list for them to identify their fall risk factors as a prompt to talk to their provider about them. And then how do you communicate this if they're at risk? You have a conversation with them. And this is part of teach-back. In our teach-back strategies, we talk to them. 1, 2, 3. Why the top 3 risk factors? Have them tell us back and why that makes them at risk for falls and why it's important to call for help. But we also include in that what happens if you choose not to call for help, because people have a right to make a choice. So some other questions that you see here. I don't know if we have time to go through all of them, but look at when those falls overnight. It's not related to less staffing. Staffing of itself is not the issue. It's how you actually manage your care. So what I really want to be able to do is, because there was an IOM report that came out keeping nurse staffing, keeping patients safe, and that actually showed with more staffing your fall rates went up. So it's not just an issue of staff. But what I want to be able to do is find ways to do surveillance. And the AHRQ system, the CareView system, is a way to do this even in a dark room where you could be watching people who you really worry about. And then getting to know them. And the literature has shown effectiveness of a particular bundle of interventions for high fall risk. No, you don't want to focus on high fall risk, but you want to focus on risk factors. So you want to move away from low, moderate, or high fall risk and assume that everyone in the hospital is high fall risk, because none of those are 100% accurate. You look at the bundled interventions that we put in place for the ABCS. That's in place for reducing injury risk. So look at that kind of a bundle, but don't focus on high fall risk. Fallers, you've got to get to the post-fall. Best practices, the list of best practices that we put together, we're starting from scratch, is to go after actual known risk factors and work people and help staff learn about them. Teach staff how to assess postural hypotension and see if they can identify people who never knew that they had it, because not everybody's symptomatic. So try and do that. Try and get to actual focus on clinical practice. Helping staff go back and look at every patient who's diabetic and make sure that they're assessing, can the patient feel their feet. You want to focus on practice. Quite a few of the falls on rehab units are people being lowered to the ground or a chair by a therapist, and that's because their knees are buckling or they're orthostatic. So when you're starting to look at these kinds of patients that are assisted falls, you still need to know why is this patient falling, whether it's with a therapist or whether it's with the nursing staff. We hope that this has been helpful. In measuring falls, there's different ways you can measure and calculate your fall rate. The NQI database has 4 or 5 different definitions for their denominator. Your numerator is always the number of falls. But remember, even NDNQI is going after types of falls. But your dead days of care, there's different ways of being able to evaluate it. And then for the observation patients, if they're there on the 24th hour at midnight, then they're included in one of those rates. So you'd have to know which one that you're actually using. lethal injury prevention strategies that we've been implementing over the years, and this comes to the AHRQ Toolkit as well. Sure, you get rid of all sharp edges and you reduce trauma if someone was to fall in your care. And do remember, colleagues, that there are multiple resources available to you. Of course, you've been working with the AHRQ Toolkit. We've had the VA one for years. We were the first toolkit, 2004, updated it in just 2012. For Clinical Systems Improvement has a toolkit, and they're focused on injury reduction as well. It was updated in 2012. It was a prior one. And, of course, AHRQ's work. All of these referenced in the Sentinel Alert that came out of the Joint Commission. So do try and focus on protecting people from injury, because it's injury that results in loss of function or loss of life. Do and integrate injury risk and injury history into your admission assessment protocol, just like Joint Commission is recommending now, and we have been doing in the VA for years. Institute for Healthcare Improvement has been helping people to do since 2008. And look at implementing some universal injury reduction strategies and go after that population-based approach to injury reduction. Stay out of the box. Go after protecting people over the age of 85 when you know that that's about 10% of your inpatient population in today's world. So you got to do something different. So for me, I fall a lot. So I have 3 boys at home, and my boys are basset hounds. So this is where you get to see my Mr. Goober, my Oreo, and my Jethro. So I know why I fall. And we all know our risk factors and not be afraid of saying why we're at risk for falls. But colleagues, it does get personal. So to look at my closing slide with my mom. My mom did have severe Alzheimer's, and my mom could walk, and my mom couldn't feel her feet at all, and my mom was at risk for serious injury when she fell. She fell in my arms, she fell in my care. You can't prevent them all, so don't beat yourself up, but my mom did not die from a fall. And when you see her here, this is when our house is no longer safe enough for her, and my husband and I in a nursing home that was just the best it could ever be and did so much more for her than we could ever do. It's just 2 people trying to keep her safe. But, you know, it is about quality of life and keeping them just loved and safe as much as we can and feeling good about each and every day. So as we got ready to dance here, everyone wanted to join us too. But, you know, I do hope that this has been helpful to you, because maybe some of you on this call are taking care of your mother, your father, your grandmother, your grandfather, because all of us really, you know, it does get personal for all of us. So I hope that this has been helpful. And, you know, I didn't get to say this, but I'll say it very briefly. I didn't have a slide on this, but in January of 2015, there was a report that came out on the epidemiology of the aging inpatient population. It's that data from 2000 to 2010. It was published by the review of the National Center for Health Statistics, CDC report. It was a brief, and it showed that over 45% of the patients in hospitals was over the age of 85. And then when you broke that down to 19% are over the age of 75, this is your repeat falling population, 9% of the patients were over the age of 85. So we have a very vulnerable population. We have an aging population, and you have to do something different. You just cannot be out there trying to prevent falls and think you're going to be effective. And that's why, for us, our primary outcome has been make sure that no one dies from a fall and no one breaks a hip because of the increased mortality and the burden that's associated with hip fractures. So Michelle and Gloria, I know I went over that, but I never have enough time. So
we had a lot to address. So
I know people have stayed, and I know that we probably, but I will always answer questions, and hopefully I'll be able to be on in January. But I'd like to invite Patricia Dykes or Julia or Kate if there's anything that they'd like to add, because they've stayed with us too.
Yeah, feel free, please do. And I know most people are probably going to have to get off. Everybody's got tight time schedules, but let me just say this. First of all, thank you so much, Pat. That was a wonderful presentation, and I know that you could have spent a lot more time talking through all of these things. What we will do is synthesize. What we will do is synthesize all of this feedback that we heard from Pat. We'll make sure that all of our experts can weigh in and add to it all those questions that everybody had. And when we share the meeting summary, it will include that summary of responses to those questions. So we hope that this has been helpful for everyone. And remember, next month we will be hearing from Patricia Dykes, so I think that that's also going to be a really valuable presentation. So thank you, everyone, for sticking around. I know we went over, and thanks again, Pat, for everything you had to offer here today. And if you wouldn't mind, please completing the evaluation as you exit the system. We appreciate that.
Thank you.
if there are any questions that anybody wants to ask real quick, we're certainly here to answer them. Otherwise, we understand that the time went over. So did any of our other experts want to chime in on anything, or were there any questions? I don't see any at this point. Well, given that, I think we'll go ahead and just go and end the webinar today. So thank you again, Matt.
Thank you so much, and happy holidays to everybody, to your family, everybody, your friends. And thank you, Michelle, and thank you, Gloria.
Thank you so much.
Sure thing.
Goodbye, everyone.
Bye-bye.